All right, let's get straight into it. This is a high-stakes clinical crash course on mitral stenosis. Focus, no time to waste. Here are the absolute essentials you need to know right now. Mitral stenosis. It's a narrowing of the mitral valve. The cause? Almost always rheumatic heart disease, period. The classic visual you need to lock in your brain? The fish mouth valve. That's your exam buzzword. Okay, the sounds. 2 of them. 1, an opening snap. 2, a mid-diastolic rumble. Got it? Here's your key diagnostic clue. The shorter the time between S2 and that snap, the worse the stenosis. Shorter interval, more severe disease. What happens next? Left atrial pressure skyrockets. That leads to atrial fibrillation. It leads to pulmonary edema. Think about it, a pregnant patient who's suddenly short of breath, you better have mitral stenosis on your differential. Let's go. A mandatory international medical disclaimer. This content is for educational purposes for USMLE and international boards only. It is not and should not be considered medical advice. Always consult official guidelines and a specialist physician. Okay, let's tackle a really common question. You know, if mitral stenosis takes years, sometimes decades, to develop, does that mean we should only expect to see it in older patients? Well, not exactly, and this is a super important clinical pearl. Even though it's a slow, chronic process, the disease often unmasks itself during periods of major stress. The classic example you'll see on every board exam is pregnancy. Why? Because the heart rate goes up, diastolic filling time gets shorter, and suddenly that obstruction becomes a huge problem. And this brings me to what is probably the single most important point I'm going to make. When it comes to actually managing these patients, deciding on an intervention, do not guess. You have to read the source. And what are those sources? These are your critical resources. The 2021 ESC guidelines on valvular heart disease and the 2020 AHA/ACC guideline. I am not kidding when I say this. You must read these. We've linked them for you. All those specific numbers, the valve area, the pressure gradients, the criteria for intervention, they're all defined right there. That's what you need to know. So let's really get into the weeds on these sounds. What exactly is that opening snap? Well, think of it like a rusty, stiff door hinge. The pressure's building up in the left atrium, and then bam, it finally forces that stiff mitral valve open. That high-pitched snap you hear, that's the sound of the valve finally giving way. Okay, so the valve has snapped open. What happens next? All that blood has to rush through this tiny, narrow opening. That creates a ton of turbulence, right? And that turbulent flow is what we hear as that low-pitched mid-diastolic rumble. Now, let's circle back to that S2 to snap interval. Why does a shorter interval mean the disease is more severe? It's just simple physics, really. The aortic valve closes, that's your S2. Then we wait for the mitral valve to open. If the pressure in the left atrium is incredibly high, it's going to force that stiff mitral valve open sooner. A shorter wait time means higher pressure, and higher pressure means a tighter, more severe stenosis. It's that direct. And let's trace the downstream consequences of that high pressure. What happens when you're constantly stretching out the muscle of that left atrium? Well, those stretched muscle fibers lead to chaotic, disorganized electrical signals. And what does that give you? Atrial fibrillation. It's a perfect example of a mechanical problem causing an electrical one. So that brings me to our question of the day. And this is for everyone out there, whether you're a student or a seasoned clinician. Have you actually, with your own ears, heard a real opening snap on a patient? Or did you find it really tough to tell it apart from, say, a split S2? I'd love to hear about your experience, so drop a comment below. All right, let's lock this in. Time for the memory anchor. Repeat after me. Snap is the open. Rumble is the flow.
Rheumatic is the cause.
Shorter is the worst. And the most important one, links review. Fantastic work. You've just nailed the tight stenotic valve. But what happens when the valve isn't tight? What if it's leaking? That's what we're covering next. Join us for Module 2, Mitral Regurgitation.